Okay, Assalamu alaikum. Welcome everyone on board. So today we will just continue our uh, discussion from where we stopped. Um, Iqra, can you tell me like what are the challenges or what are the concerns in endoscopy suit?
Sir, should I explain?
Okay, okay, you can tell.
Sir, first of all, that is a periphery area, so the appropriate equipment and appropriate training will not be available there. That is the main challenge uh, whenever we are
What
performing
do you mean by
like
training?
endoscopies or anything else.
What do you mean by
Sir,
training? Training is not a
sir,
training is not a good word.
sometimes
Training is not a good word. You can say limited
okay,
manpower. Okay.
exactly, sir. Okay, sir. Okay.
Okay. So,
And then
so
there there is a conflict of interest, like we prepare our things as per our need, but the staff of ERCP department, like there is a conflict of interest, like matlab,
I think
our
I
team
think no
is
no no
not
no this is also
is
not a
not
good
dominated.
this is also not a good choice of word. Conflict of interest never occurs. Okay. I don't think so. This is a good word. Out of war is limited manpower, unfamiliar environment. Okay. What else? Anything else, Hush, please?
Sir, inexperienced staff and concerns related to the conditions
You know why
of the
why you
patient
are
underlying
writing why you are
coming for
telling
endoscopy.
no, no, no. I'm sorry. Inexperienced staff. What do you mean by inexperienced staff? This is not a valid. From where did have you read about it? This is not a good word. Inexperienced staff is not a good word. Unfamiliar environment, yes, because it's their place. It's not your place. Okay, you are not going frequently. So unfamiliar environment is a good word. Limited manpower. You
Sir,
will have
limited
one
sir,
anesthetic.
limited access to the airway, shared airway. Limited access
Yes,
to the
this is
airway.
very good. This is
Sir,
this is
limited access to the airway, shared airway.
very good. Limited access to a risk of aspiration.
طيب.
Okay. What else?
حاضر.
Risk of aspiration. Anything else? Okay. Just tell me one thing. What sort of patients come here? Like if you just
Sir,
think
morbidly obese patients.
morbidly obese patient for what?
Sir, patient with increased.
Just a second. Morbidly obese
Sir,
patient for what?
what I have seen in they came for ERCP like obstruction.
Why
They
only?
these
Why
patients are
only?
you
Why
know
only? Can thin
obese.
lean patient cannot come to ERCP?
Sir, they do, but majority of them are usually
No.
from, sir, sort of
I will.
high
I
socioeconomic class with a sedentary lifestyle.
no 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 no. No, 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 not necessarily. Yeah, you can explain in that for one thing that if we are going for bariatric surgery, the people who are going for bariatric surgery, they are coming for endoscopy, like gastroscopy. Sometimes they are seeing before doing bariatric surgery, but it does not like it's not a valid point that only morbidly obese patients are coming. No, okay. So there are group now. Now let's see that how which group of people are coming. People who have some biliary problem, biliary tree problem, either obstruction with obstructive jaundice, gallstones, migrating and blocking jaundice. So this is one group. Post liver transplant patient. Okay, they are one group of people who are coming. Then please try to keep your mic mute. The one who wants to speak is welcome, but please don't disturb. Thank you. Okay, so post liver transplant, there are pediatric patients with congenital uh, problems. Okay, and they are also coming for ERCP. For endoscopic procedure. So, like there will be some procedures which are from upper part, and there are some, like there is the procedures which are there are ERCP, diagnostic as well as therapeutic, for placement of stent, for removal of stone. Okay, then endoscopy, gastroscopy or duodenoscopy for ulcer obstruction. Then this one, diagnosis of carcinoma. They are taking biopsies as well. The gastrointestinal, reflux disease. Okay, GERD. Then, uh, like if we are talking about colonoscopy, so again, maybe they are finding people who are having melena or this hematochezia. What do you say, hematochezia, something like that. I'm not using the correct pronunciation, I suppose. And they are for like diagnosis of polyps or do you know there is one problem which is following antibiotics. Do you know the name of that this problem? If you are using high doses of antibiotics, there is something which can occur.
Pseudomembranous,
Very good, very
pseudomembranous,
good, very good.
pseudomembranous colitis.
Pseudomembranous colitis. Okay. So, so these are the things with reference to the procedure, as we discussed that aspiration problem. And then another challenge is that a number of time there are chances of vagal responses. Okay. Then another thing, uh, there, what is MAC here? Use of MAC. How will you define monitored anesthesia?
Monitored anesthesia care, sir.
Okay, how will you define? How will you explain what is monitored anesthesia care? Yes, Ikra. What is monitored anesthesia care?
Sir, we provide the anesthesia care without doing or manipulating anything. We just have to monitor the patient
With or
regarding the
without?
vitals and
With or without?
necessary airway.
No, with or without. Not necessarily that
With
we
or
don't.
without. Okay, sir.
With or without. Okay. With or without giving anesthesia. So it is provision of presence of trained anesthesia care, having standard 1, standard 2 monitoring, with or without giving anesthesia. Okay, maybe local anesthesia is given by the surgeon. Like the example of is a number of time monitored anesthesia care can be given here for ERCP. Sorry, for especially gastroscopy, but mild sedation, what you say, procedural sedation. Okay, procedural sedation. So, then another example is cataract surgery. Another example is any surgery occurring under local, and you are monitoring. Like there are so many things like carpal tunnel release. You can have now so many example of the surgeries which are being done under monitored anesthesia care. Okay, so you should be knowing. So like procedural sedation is another terminology you should know to explain. And then how will you assess the level of sedation? It's through Ramsay scale. You should know how to explain Ramsay scale. Okay, Ramsay scale for assessing the level of sedation. Okay, so what is conscious
Sir,
sedation?
sorry to interrupt.
Yes.
So do the procedures named like evaluation under anesthesia come under these monitored anesthesia care procedures or not?
UA, examination under anesthesia.
Yes, sir, like these.
Okay,
Yes, or
let's discuss three things. What is conscious sedation? What is deep sedation? And what is GA? What is conscious? How can you explain conscious sedation?
Assalamualaikum, sir.
Walaikum assalam.
sir, from which patient can be awakened? Is the conscious sedation?
Like you are sleeping
Conscious
and I say,
sedation, sir, when you
just a
do
second,
some
just a second,
sedation,
please. Don't interrupt in between,
when
Dr.
you are
Ramzan.
doing,
Let her speak and then I will give you chance to speak, please. Yes, please again try Iqra.
Yes, sir.
The name isn't a funny name.
Sir,
Conscious sedation isn't a funny name.
yes, sir.
Patient is calm,
So
quiet,
patient is
relax.
yes, sir. But he
Okay.
can
Yes, I just asked Iqra and you are opening the eyes. Or we are just tapping you very lightly and you are opening the eyes. Like with minimum stimulation or verbal communication. Patient is communicating. Okay.
okay, minimum.
So this is like
Yes, sir.
we don't have to slap you, okay, to get your response, or we don't need to pinch you to get your response. We are just calling you by name, the patient's name, or we are just tapping and the patient is responding. So that is called as conscious sedation, calm, quiet, relax. And I'm very bad in remembering the numbers and gadget. Sorry, exact. So you should be telling with the Ramsey scale. Okay, with reference of Ramsey scale, you will have. So I think
RAM
it
3
should
and
be
4.
0 or 1, something like that. If I'm not wrong, just reconfirm it. But
Sir,
Ramsey
3 and
scale
4. 3 and 4.
Ramsey sedation scale is the one by
Sir,
you by
RAM
which
3 and 4.
Ramsey 3 is and 4 is too much. Ramsey 3, 4 is too much.
Ramses
Sir,
2, sir.
I'm sorry?
Two, sir, 2.
sir, I think
Yes.
so. You are mixing RAS and Ramsey. Ramsey 3 and 4 is conscious.
Okay. Just a second. Just a second. Let's confirm it. Ramsey sedation scale.
It is the stage 2, sir.
Yes, that's what I just want to reconfirm. Anyways, because RAS is something else. RAS is for which condition, Hassam? That is for
ICU
Richmond
both, sir. ICU.
agitation sedation scale.
Delirium.
That is for
Delirium.
delirium.
That is for delirium. Delirium.
Yes.
Hmm.
So very good. That's how we learn every day. So it's light tactile stimuli or loud auditory stimulus. You are right. You were wrong. Okay, so thank you for correction. That's why I tell you I'm very bad in remembering the numbers, remembering the scores. I can give you the concept. I don't remember with the numbers. Thank you. So actually, one is anxious. There is one modified also. Let's see. Hassam, do you remember what is difference between modified Ramsey scale and this the other one? Is there any difference?
No, sir. No, sir, maybe there is modified Ramsey, but I actually recall this Ramsey. Yes.
Yes, but the basic thing is that the patient
Sir, this
is
I also got to learn from your lecture.
no, but I forgot. I'm very bad in recalling. That's why you see, I told you the patient is responding to light stimulus or verbal command. Okay, so that was I correct, but I don't remember the levels, the 1, 2, 3, 4. So that I always forget. Okay, so I'm half correct, half wrong. Okay, so thank you. But actually, remember one thing. If you tell in the number in the concept and you fail to tell the number, they will not fail you. I can guarantee you. Okay. So try to be, even in the exam, if you forget the exact thing, try to give the concept. So the concept of conscious sedation is this one. Okay. So now next step. What is difference between deep sedation? So 5 and 6 will be deep sedation. Okay. So just tell me what is difference between deep sedation and GA. Yes, Dr. Ramzan, you want to tell? You can tell now because actually they are, some of them are exam candidates, so I'm giving the chance to them.
Okay, sir. Actually, I can give it from the start. If the patient is fully conscious, but he is anxious about the procedure, so sometimes patient not cooperative. So we give light dose of any sedative medication. Patient become calm, but he is oriented. When you call, he is okay. This is stage
Yes.
one. But if you give little more dose, patient is more comfortable, maybe little sleepy. When you give him verbal command or little tactile sensation, he will be awake. That
Mm.
is called conscious sedation. That is the stage two. So in stage three, that is called deep sedation. In this patient, you have to give either deep stimuli or repeated stimuli.
You're right.
Usually we are in stage two is a conscious sedation,
No, no,
mild
no,
cases, but light endoscopy cases, other we are giving deep sedation. But what is the difference between anesthesia and deep sedation is this the stage in which patient don't give any kind of response if whatever
no,
you stimulus give, that is called anesthesia.
no,
But
no, 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 no,
anesthesia is a combination of medication.
no, Dr. Ramzan, you just need to correct a little bit of concept. If you are not able to maintain the airway, that becomes general anesthesia.
No,
In
sir,
general
that is the
anesthesia,
that
you
we
need to
that we, no,
we need
yes,
to
sir. That is
maintain.
the another thing. What can happen? What can happen in the vitals? What can happen airway? That depends on the sedation. That is another issue. In deep sedation and general anesthesia, you have to maintain the airway and vitals also may be
No, no,
affected.
Doctor
But
Dr.
we are
Ramzan.
talking just level of.
No, Dr. Ramzan,
Yes,
sorry to
sir.
correct you again. I'm sorry to interrupt and correct you. The difference between deep sedation and general anesthesia, in general anesthesia, you need to maintain the airway. Okay? In deep sedation, you don't need to maintain the airway. Patient is not responding to your stimulus, but maintaining the airway. So as you correctly said that in ERCP, we usually need deep sedation. Okay? But still we can maintain the airway.
Yes, sir.
But if we need, if the level is even further more, and patient for any good reason, they actually, there is window is very little margin of error between deep sedation and GA. Okay. And the other thing which you are
Yes,
telling is
sir. Yes,
about
you are correct.
among
That's what I.
the choice of a medication, like if you are using midazolam plus fentanyl plus propofol. Okay, there is more chances that the patient will not be able to maintain the airway if you give a little more dose, and then you need to maintain the airway. However, if you are using, instead of
Yes, sir. Yes, sir.
propofol, you are using
You are
Presidex.
sir
You are
correct. Sir, what are you talking? You are correct. I am talking about level of sedation. Then what kind of sedation affect your airway as well as vitals? So vital also like blood pressure, heart rate can be affected by sedation. Airway also affected. So stage deep sedation, you may not need airway maintenance, but in anesthesia, deep anesthesia, you need to maintain the airway. That is the separate complication or you can side effect of the sedation. But when we are talking just level of sedation, that is depend upon the stimulus and response of the body,
yes, and
response
actually
of the
we
patient.
that even I did not remember exactly. So this is the Ramsey scale. Okay, I hope Ikra and Hassam,
Sir,
you are
may I ask
clear.
a question?
Yes, we are stuck on this small point. I want to
Sir,
move
sir,
forward.
isn't
Yes,
this
Ikra.
that there is the difference of muscular relaxation?
No, muscle relaxation is, do you know,
Sir, I
it's
was
now
asking that.
it's no way here. In the muscle relaxation is not the
Muscle
consideration here. Of
relaxant is
course,
not included. It is just to
if you give
facilitate the surgery.
muscle relaxant, of course you need to maintain the airway. How can you maintain how can you like keep with, if you are using muscle relaxant, you definitely have to maintain the airway. Okay. And remember one thing, because in
Yes, sir. Then
Pakistan, in Pakistan, we don't even consider. That's why I told, for the first time, when I came to Saudi Arabia, I came to know that we can give anesthesia without muscle relaxant as well, even intubation, and a lot of things we can do without muscle relaxant. Okay, so the it's not matter of muscle relaxation here. Yes, what else you want to ask?
Sir, second
okay,
thing,
sir.
that
This is
muscle
fine.
relaxant, when
You
we are giving muscle relaxant, that if you don't give muscle relaxant, you have to give high dose of the sedative medications. It will affect
yes,
vitals, it affect the airway. When you give muscle relaxant, it facilitates the surgery, but you need to reduce your all deep sedations, drugs, and all other side effects from the other medication. So this is the benefit of muscle relaxant. But without muscle relaxant, anesthesia can be given, okay, but
yes,
facilitate the surgery and reduce your
yes.
medication dose and side effect of the doses. Muscle relaxant is beneficial.
Okay, Ikra, what else you are asking?
Sir, should I speak something?
Yes, please. I want to go move forward. We are stuck on this small point.
Sir,
I
I was
have.
actually
Yes, please speak out quickly.
Sir, what I believe is that we are just here to gain the basic idea which we have to deliver in front of the examiner. We can learn the exact word by ourselves. That's
Yes,
our responsibility. We are here
yes.
to
Yeah,
get the idea
I
of
hope that.
what
Okay,
examiner
okay,
wants to
okay.
ask from
Ikra, and
us.
what is your point, Ikra?
Sir, I was just thinking of the steps of anesthesia. Actually, that were induction and then the maintenance and then muscle relaxation. That's why I
No,
was
no, no,
thinking
no.
that is
Please,
it
that is
the
no, no,
main
no, no. Please don't do the mistake. That
in
is the
the
stages of
anesthesia and the deep
anesthesia.
sedation?
That is the anesthesia as stages of anesthesia. Okay, so please don't mix up. This is, we are talking about
All
level
right,
of
sir.
sedation. That is stages of anesthesia. Okay, so that is something else. I'm sorry.
What is the Thomas's score? So Thomas is a score for sedated patient
Uh,
and for ICU patient. What is the difference?
any there
I'm
is no
sorry. I cannot hear. What are you saying, Dr. Mirha? But please speak out loudly. I don't listen. I cannot hear. Anyways, if you are talking
sir.
about, yes.
There is Sir, there is no collaboration of stages of anesthesia in the conscious sedation or deep sedation. Like we have to study conscious sedation and deep sedation separately, and the
Yes, yes,
stages of
yes.
anesthesia separately.
It has no
Is
relation.
that the
That's why I'm
idea
saying
you want to
this is.
deliver?
No, no, no. That is totally different thing. Stages of anesthesia is totally different thing. We are talking about level of sedation, okay? And level of sedation is through Ramsay scale, as I we have discussed. The numbers I had confusion. The number is we saw the text and we are now clear. Okay, so I will move forward because we are wasting time. I don't want to waste your time because I want to cover as much as possible. You can just cram from here, but the concept I have told you, conscious sedation, the verbal communication with minimum response, patient will respond. Deep sedation, patient will not respond to ordinary stimulus but maintain the airway. General anesthesia, you need to maintain the airway. Maintain the airway. That is the concept of monitored anesthesia care, procedural sedation, conscious sedation, deep sedation, and general anesthesia. This can be asked in the exam. With reference to ERCP, usually deep sedation is required. Risk of aspiration is there, and another problem in that some of the people can do it in supine position, sorry, lateral position, but a number of people, they are doing it in prone, okay, or semi prone. So in semi prone position, it is difficult to maintain the airway. So if you have any doubt or any chance, as Dr. Ramzan was mentioning, that if you are giving muscle relaxant and maintaining the airway, the drug requirement of other medication will be reduced. So he was absolutely pinpoint in the concept that if you are using multiple medications, you are giving muscle relaxant, the dose requirement of anesthesia will be reduced. But Remember, this is a very important concept to be cleared, that if you are not maintaining the level of sedation, level of hypnosis, as like requirement of anesthesia is 40 to 60 bis or more than 1 Mach, okay? If you are not maintaining it, patient can have awareness. Okay, so whenever you are using muscle relaxant, the chances of awareness will be increased. The dose requirement will be reduced, but the chances of awareness will be increased. So I hope this is a very important concept which you need to be clarified. Okay. I hope I am clear. This always you are not monitoring, of course. Okay, but the concept is that you need to maintain the level of with this one. And if you are not maintaining the level of anesthesia, the patient will have awareness, especially when you are using muscle relaxant. So ERCP, we discussed a few things: endoscopy, gastroscopy, colonoscopy. There are diagnostic procedures, there are therapeutic procedures, and there are procedures to control the bleeding, even sclerotherapy, okay, botox injection. There are so many things which they are doing. The challenges which we start from where we started, it's out of OR environment. There is limited manpower, there is limited access to the patient, shared airway. So these are the things which you should be knowing. Then another thing is that if you are using, another important thing is use of local anesthesia gargles. Okay. So if you are using good amount of gargles or good amount of lubrication, as in colonoscopy, again you will require reduce the dose of anesthesia. If you are using good amount of lubrication, the amount of anesthesia you will be giving will be reduced. So even I use this thing very frequently. If you are able to have a good amount of this one airway, like local anesthesia, you have used the gargle, the same things which you are using in awake fiber optic. So same theory if you apply here, because actually when they are cutting something, actually there is no pain. The pain is occurring when there is a stretch. If you are cutting the the mucosa, there is not much pain. Okay. So like they are taking the biopsy. The main critical step is when they are passing through the throat. When they once they enter the esophagus, when they are already in the stomach, there is not much of pain. Okay. So few more thing. If you are using opioids, can someone tell, please, one person who want to answer, just tell please, what are the problems associated with the opioids? So Assam, Assam
Sir,
is
they
left.
generally cause sphincter of Oddi constriction.
Okay, sphincter of Oddi tone. So opioid-free anesthesia will prevent this thing. Okay. So because if you are using it, then they are using
Sir, and
glucagon, or they are using no spa, like antispasmodic.
hyoscine.
Hyoscine, antispasmodic, no spa, or like Buscopan they are using as a antispasmodic. Okay. So if you are using a medication which are maintaining the airway, and they are so actually they are good. Okay. And another thing is that a number of time there are like, for example, if there is carcinoma, any biliary, like patient with the CA head of pancreas, or cholangiocarcinoma, or anything. So these are patient with multiple comorbidities. Okay. So obesity, as Hasham was mentioning, the obesity patient, they are coming before lapse bariatric surgery. They are coming for this endoscopy. A number of time they are coming for endoscopy before going for the like lap sleeve gastrectomy or gastric bypass. So this is all about ERCP, colonoscopy, chances of vagal stimulation, and I have tried to cover. If they are asking you, because the same question was asked to me, and I even did not have hear about monitored anesthesia care, so I cannot forget MAC. So I said it is minimum alveolar concentration. They said no, monitored anesthesia care, and I had no idea whatsoever. So things change in 12 years. I'm teaching you. Okay. So this is one of the topic which I wanted to cover today. The other topic which I want to cover, I don't think so we will be able to cover the third topic. So role of ERAS in GI surgery. Okay. So actually ERAS, they can ask you enhanced recovery after surgery protocol. They are using it in almost all the surgeries now, one by one. Say they started with colorectal surgeries and a knee arthroplasty and hip arthroplasty, and they are trying to do it in majority surgery. So who has read this topic? Who wants to speak out, please? Faiza, you have not spoken up till now. Please, you want to tell what is the role of ERAS in GI surgery? It is
Sir,
enhanced
its
after
role
surgery.
is early recovery, early mobilization, decrease use of NG and removal of NG tube as soon as possible, early nutritional support, and early removal of the catheters. These are the things, few things, and less use of opioids.
First of all,
And the
your
surgery should be done by a senior
Faiza,
surgeon.
Faiza, please try to organize your answer. Okay. Please try to organize your answer. Your answer is not organized. I asked what is the aim of doing ERAS. So you are mixing the things. The main role of ERAS is to reduce the morbidity and mortality and reduce the hospital stay. This is the main aim. And now how to do it? Then there are these are the things which you were telling. So one of them is minimize NPO, no bowel preparation. Okay. Rather, there is a nutritional support, nutritional plan, which is being used over. There is a special team which is making the patient ready for the surgery, any bowel surgery for either carcinoma or any reconstruction or anything. Okay. So there is no bowel preparation before, because before they used to bombard the gut by laxatives. Okay. So it causes a lot of electrolyte imbalance. It causes result in ileus. It causes result in dehydration. So it was a big problem. So they don't know. NPO both pre-operatively and post-operatively. Again, purpose is to minimize the stress response and get the early ambulation and early discharge from the hospital. So if someone asks you what is the aim to do ERAS, you should answer this thing. And how to do it? There will be some anesthetic factors, patient surgical factors. So minimum invasive surgery, like laparoscopic surgery versus open surgery. Okay, so always choose laparoscopic surgery. Like the other another terminology is MIS, minimum invasive surgery. So these are the thing. No NG, no drains. Minimize the use of drains. Okay, opioid free anesthesia. Then uh, goal directed fluid therapy. Then this one uh, like uh, good fluid, you can say, like to avoid electrolyte as well as fluid imbalance. Okay, so then early ambulation. So okay, one more thing I wanted to tell, that even epidurals are almost obsolete in colorectal surgery. They are not using it. Okay, because epidural also delay the ambulation. You can reduce the concentration, but still use of epidural will delay the ambulation. So actually they are not using epidurals. Let me see that what else we need to. Okay, so, and of course pre-op preparation. Okay, optimization of the condition, correction of anemia, correction of any chronic disease like COPD, hypertension, ischemic heart disease, diabetic control. So this is all like any other disease. So when we'll be minimizing the NPO, we will be giving a carbohydrate drink, like this is written, carbohydrate loading. And when you are using carbohydrate loading, there is reduced stress response, because if there is a lot of stress, this stress hormones are released, it has bad impact on the wound healing. It has bad impact on the organ system. Like there will be increased myocardial oxygen demand supply ratio. There is like tachycardia. So role of multimodal analgesia is also part of ERAS protocol. Okay. So optimizing, managing pre-existing morbidities, discharge plane, they have to everything is programmed. Okay. So no reduce or no or reduced oral bowel preparation, as I told you. Plan mobilization, rapid dehydration and nourishment, appropriate IV therapy, no wound drains. Okay. No NG. Catheters removed early. Regular oral analgesia rather than IV. Okay. Paracetamol and NSAIDs. Avoidance of systemic opioid-based analgesia where possible or administered topically. Okay. Then shared decision making, optimized health conditions. So if they are asking you another thing, you see, minimal invasive surgery, use of transfers in CNs, as an epidural management increase, like the it will also delay that hospital discharge and delay the ambulation. Okay, so these are the thing which they can
Excuse me,
ask
sir.
you.
Can I ask
Yes,
a
yes,
question?
yes, please. Yes, please.
Sir, I want to ask that what are the basic teams? What are the basic teams that are involved in the enhanced recovery or after surgery program? Like which team? Nursing teams, anesthesia team, surgery team. Which more personnel
Actually, we
apart
will
from
discuss
these three basic
this
teams?
question. There is a chance if I were your examiner, I would have put this topic because this is future. Because anesthetists are perioperative physician. So actually, this is all domain of perioperative medicine. You will find an article on perioperative medicine. We will just try to have a look on this topic. This is my area of interest. So there are so many teams. Whatever teams are required for better outcome.
Sir,
So
can you please show that picture again?
I'm sorry. Which picture? This one?
Sir, can you please show that picture again?
This one?
The flow chart containing pre-op, intra-op, per-op.
Yes.
No, sir, you just opened a flow chart.
Uh, which flowchart? I'm sorry. About which? About what?
Sir, just before this page, you opened a ERAS protocol page.
So it is there. This is the one you are talking.
Yes, sir. Sir, thank you.
Okay. So actually, all these articles are there. Unfortunately, some of you are in habit of using them, but majority don't use it. So that's why it remains unattended to you. So you see, these are the things which they they consider. Epidural, epidural will be used in if it is the risk versus benefit, there are more benefits. So, but otherwise, not the routine use of, like in laparoscopic surgery, there is no use, there is no need of epidurals. And majority of now colorectal surgeries are laparoscopic. So actually, they don't need it. So that's the reason. Okay. Okay. So I think we will not be able to have the other this because there is I found a very good article on GI problems in intensive care. So I think we will discuss tomorrow this topic. So today we discuss about endoscopy anesthesia and we discuss some points about ERAS. Actually, ERAS is a topic which they can ask you. And like anything which is delaying the ambulation is not appreciated. Like if you are talking about knee surgery, they don't want you to give epidurals. They don't want you to give femoral nerve block. They don't want you to give popliteal block. They want you to give adductor canal block, which is only blocking the sensory saphenous nerve. And they are injecting opioid and sorry, local anesthetic in the joint. They are giving so these are the things which instead of giving epidural in abdominal wherever possible, they are giving tab block because tab block will not cause motor loss. Okay, so I think that's it for today, and inshallah tomorrow we will continue our. I was thinking that maybe day after tomorrow we will do liver. I think we will need some one or two more sessions. Okay. So thank you very much. And if any question before I finish, anyone wants to ask any question? Yes. So Dr. Ramzan, where I will, you were not here. I was saying something that when you raised a point about use of muscle relaxant, decreasing the requirement of anesthesia. So you are exactly right in that thing. Only one thing I added that whenever you are using muscle relaxant, chances of awareness are increased. So if you are not able to maintain the certain level of anesthesia as as monitored through BIS or MAC value, we don't have this agent analyzer in which you are having end-tidal agent level and you are calculating the MAC value in the through the automate system. There may be chances of awareness. Otherwise, if you are using muscle relaxant, the requirement of anesthesia medication will be reduced. So the hemodynamic effects of the anesthetic medications like even sevoflurane, if you are using in high MAC, there will be significant hemodynamic effect. If you are using muscle relaxant, the requirement of propofol will also be decreased. If you are using multimodal analgesia, using some ketamine, some lidocaine, good amount of analgesia, so the requirement will be decreased. Okay. So I just repeated the thing I said when you were not here. So thank you very much, all of you. And tomorrow, inshallah, we will discuss this topic
Assalamualaikum,
of
sir.
GI problems in ICU.
Assalamualaikum,
Oh,
sir. Sorry, sir. Sir, Dr.
oh,
Vishant, sir,
actually,
1 minute only.
I have to leave, Dr. Ramzan. I'm really sorry. If you can quickly say, okay, please.
Yes, only one point I want to, because mostly in our group are students, okay? So when you are using the MAC, usually MAC, we must know what is awake MAC, because you
MAC
told in
awake.
lecture that it should be at least one, I think. Yes,
I
it should
actually
be
it's
not
more than 0.5.
even
It's 0.5. More than 0.5. It's
point
MAC
0.3,
awake.
more than 0.3. Yes, 0.3 is a MAC, awake MAC. It should be 0.5, it is minimum at least. So that I only want to add that. Thank you very much. So nice of
And
you.
MAC bar. Similarly, there is another concept of MAC bar. So it is around 2 to 3 MAC. That is blunt adrenergic response. Okay.
Thank you, sir. Thank you. So nice of you. God bless you.
Okay. Bye bye. See you.